effective. So first we have Dr. Miriam Joseph, who is a phaco-refractive surgeon working at Arya Eye Care Hospital, Thrissur. Dr. Miriam will be presenting on beyond pink eye, conjunctivitis, drug-induced and cicatrizing conditions.
Good morning, all. So the topic given to me is beyond pink eye, conjunctivitis, drug-induced and cicatrizing conditions. So this presentation, I mainly want to give the message that everything we see as a pink eye is not pink eye. It can be drug-induced or cicatrizing. So just to make us aware of all the rare conditions which we can misdiagnose as conjunctivitis. So conjunctivitis is inflammation of conjunctiva. The main symptoms are lacrimation, grittiness, stinging, burning, and if there is pain and photophobia, we should suspect corneal involvement. Discharge, which is a main thing which we can differentiate between all these causes, is watery. If it's watery, it's viral or allergy. If it's mucoid discharge, it can be chronic allergy or dry eye. If it's mucopurulent, it can be bacterial or chlamydial conjunctivitis. If it's severe purulent, it can be usually caused by gonococcal infections. Now, just a quick walkthrough of the signs. Ciliary congestion and circumciliary congestion, we all know how to differentiate. Ciliary congestion is mainly in the palpebral area. The caliber will increase towards the periphery, and if we put topical phenylephrine, it will disappear, unlike the circumciliary congestion. So follicles are small, discrete, elevated lesions resembling grains of rice. They are usually seen in the pharynxes. Papillae are usually seen in the palpebral and the limbal bulbar conjunctiva. They have a vascular core. They appear like mosaic-like pattern of elevated red dots. The causes for this are usually bacterial allergy, contact lens wear, chronic marginal blepharitis. This is just a picture which shows how to differentiate between a papillae and follicle. Because the papillae has a vascular core, it will appear as red, raised, elevated dots, and the follicles will resemble grains of rice, and the blood vessels will be around the follicles. Now, some conjunctivitis can present with hemorrhages, usually viral. Chemosis can also be a presenting sign. Now, coming to membranes, they can be pseudomembrane or true membrane. Pseudomembranes are basically inflammatory exudates, and they can be easily peeled off from the underlying conjunctiva without any bleeding. But true membranes are integrated into the epithelium of the conjunctiva, so they will bleed when we are trying to remove it. That's how we differentiate a pseudomembrane and true membrane. Now, a feature of cicatrizal conditions are subconjunctival scarring. They can be seen in trachoma as a sequelae of membranous conjunctivitis, and severe scarring can lead on to cicatricial entropion. Another feature is preauricular lymphadenopathy. It's usually seen in viral conjunctivitis. Now, antibiotic therapy initially, and we have to provide adequate lubrication. Antibiotic ointments can be given at night to prevent the sticking, and peeling of membranes if present, and steroids can be given with caution, especially if there is membranes, to reduce the inflammation. Now, an entity called chronic bacterial conjunctivitis, which we tend to miss. This we usually tend to miss as allergic or as a chronic viral. In chronic bacterial conjunctivitis, it is usually associated with blepharitis. So we have to see the lid for this. And the most common cause is Staph aureus. Moraxella can cause chronic angular blepharoconjunctivitis. That is, there will be angular inflammation here. And we have to see the lids on all conjunctivitis patients if there is marginal ulcers in cornea. And the treatment is basically with good lid hygiene. Unless we give good lid hygiene, this condition is not going to resolve. And we can give oral doxycycline in severe cases. Something else called hyperacute bacterial conjunctivitis. This is usually seen in neonates and sexually active young adults. It's an oculogenital disease caused by gonococci and meningococci. It has profuse, thick, green-yellow discharge, painful hyperemia, tender preauricular lymphadenopathy. And if untreated, they can have corneal complications. And the treatment is basically we give topical therapy along with systemic antibiotics. That's a must in this condition, otherwise it will not resolve. Now coming to viral conjunctivitis. Basically, we all know that viral conjunctivitis is basically we give supportive treatment, and we need to educate them on hand and ocular hygiene to prevent the spread to the other eye or to others. And basically the treatment is mainly lubrication and cold compresses, topical steroids if they have subepithelial infiltrates. Now another one called HSV conjunctivitis, that is herpes simplex virus conjunctivitis. It's usually seen in children. It is usually associated with these vesicular skin lesions around the eye. That's the pointer towards HSV conjunctivitis, and they will have preauricular lymphadenopathy. It usually resolves spontaneously. We give supportive measures. If the cornea is involved, we have to give antiviral therapy. Now coming to allergic conjunctivitis. It can be acute allergic conjunctivitis which is usually seasonal or perennial, and the differentiating features are papillae, chemosis, and they will have this mucoid watery stringy discharge. There is an entity called chronic atopic conjunctivitis, that is AKC. It is usually seen in the late teens to the 5th decade. So it's a later onset allergic conjunctivitis. They have a history of eczema or asthma, and we usually see a lower tarsal papillary hypertrophy, and they can have upper tarsal cobblestone papillae also. Another entity is the vernal keratoconjunctivitis. These usually affect children and young adults, and they also have a history of atopy. It is usually exacerbated in the spring and summer months, and they have upper tarsal papillary hypertrophy, and cobblestone papillae can also be seen. Here the classic in limbal VKC, we will see these broad thickened gelatinous thickening of the superior limbus, and Horner Tranda dots, which are the white dots that you see on the superior limbus. That is how you differentiate VKC. Now, cornea can have superficial pannus, punctal epithelial keratitis, and shield ulcers, which you can see here. This is a grading system. We just need to know when to refer them to an allergy specialist. We will treat the eye part, but they will not get better unless we start the systemic therapy also. That is what we need to know in allergic conjunctivitis. So treatment is basically based on severity and chronicity. We tell them cold compresses, preservative-free lubricants which can be refrigerated, because they can apply these cold refrigerated lubricants whenever they feel the need to it, so that they can avoid eye rubbing. The drugs that we give are usually mast cell stabilizers like cromolyn sodium, antihistamines like olapatadine, alkafetine, vepostatin. In seasonal allergy conjunctivitis, when we know that the season of allergy is coming, we can give them pre-treatment with these anti-allergies. Then in severe cases in VKC atopy, we need to give them immunomodulators like topical cyclosporin and topical tacrolimus ointment. Corticosteroids are another mainstay of treatment which we need to give. So when to refer to allergy specialists, that is grade 2, 3 in VKC. That basically means that if they have persistent symptoms, even with treatment, corneal symptoms, corneal signs, then we need to refer them to an allergy specialist. They need systemic anti-allergy treatment for their condition to resolve. And if they have associated systemic features and a history of other atopy. Now another entity called allergic dermatoconjunctivitis. It is usually an allergic reaction to topical medications, cosmetics, clothing, jewelry, anything can cause this. This presents with usually severe itching and inferior palpebral papillary reaction, and they have this lower lid and canthal eczematous reaction. That is how we differentiate this. And this can go on to lid keratinization and punctal stenosis if we don't treat it. And how do we treat? This is an allergic reaction, so we eliminate the stimulus, we discontinue the medication or the cosmetic that is causing it, and we give topical antihistamines and steroids. Another entity called microbial allergic conjunctivitis. This is a new term, but we all know what it is. This is usually caused in a chronic staphylococcal blepharoconjunctivitis. It can be associated with marginal keratitis. Flictin is also another entity in this. GPC, that's giant papillary conjunctivitis, in soft contact lens wearers we usually see in ocular prosthesis and protruding sutures. In this we remove the inciting factor. This is similar to the allergic dermatoconjunctivitis, that is toxic follicular conjunctivitis, usually seen with topical medications, or molluscum contagiosum, which is seen in the lid margin, pityriasis pubis on the lid margins, cosmetics. This also we discontinue the medication or we treat the underlying condition. Now come a few slides about the cicatrizing conjunctivitis conditions. That is, one is ocular cicatricial pemphigoid. This is a chronic progressive condition. We need to have this suspicion in our mind when we see a chronic patient of conjunctivitis, because this is a progressive condition which can go on to cicatrizing complications. Now another is Stevens-Johnson syndrome, which is, we all know it's caused by allergic reaction to drugs. Usually it's non-progressive. That's the differentiating between the OCP and the Stevens-Johnson syndrome. I'm not going into all these details. Another which I want to say is the drug-induced cicatrizing conjunctivitis, which has cicatrizing sequelae. It is not just a conjunctivitis. If we don't treat it, it can go on to cicatrization. That's all. Thank you.